Society of Breast Cancer Study and Global Cancer Institute for this joint collaboration breast tumor board for giving me opportunity to submit this first case. I'm Dr. Arifur Rahman, working at Banu Specialized Hospital, and our case is as below. Patient, 37 years old female, working female, without having any history of breast and ovarian cancer. This is a HER2 positive advanced stage 4 breast cancer case, and her past medical history is quite significant. She had right breast lump in 2002 and FNAC was done at that time, but that was negative for malignancy, and she underwent some homeopath for 3 to 4 months according to her statement, and the mass resolved. Gynecologic and obstructive history is not relevant. She has a baby, which her age of the last baby was 2 years, 6 months. In early February 2020, she again felt mass in the right breast and was ignored as baby was on breastfeed. Due to persistent mass, repeat FNAC was done on April 2020 from subareolar region, and report shows benign proliferative breast lesions favoring nipple adenosis with lactational change. On mid-June 2020, she developed right lower limb weakness and predominantly in toes and cannot even move with limping, but not progressive. So she was evaluated by local physician and MRI brain was done. A well-defined cystic lesion is noted in left frontal lobe at the uppermost part of prefrontal gyrus, and with hypointense on T1W1, hyperintense on T2W1, and no diffusion restriction on DW1 with marked perilesional edema. Size was about 3.2 into 2.3 into 3.2 centimeter. Compressed the adjacent gyri and sulcus. MR spectroscopy shows reduced NNA and increased choline-creatinine ratio within the lesion. Choline NN increased within and outside of the lesion. Tractography shows destruction of the nerve fibers at the anterior aspect of left-sided corona radiator. This is the image of preoperative brain MRI. So you can see the well circumscribed lesion, cystic lesion. And she was evaluated by the neurosurgeon. She underwent with solve surgery. That was awake craniotomy with gross total resection of the swell, assisted with neuronavigator, with preoperative ECOG and MEPS guidance on 21/7/2020. Paraoperative findings, tumor was cystic with grayish pink, minimally vascular, thick cyst wall. And histopathology came poorly differentiated metastatic carcinoma, suggestive adenocarcinoma. TTF1 was found negative. Postoperatively, she was conscious, alert, oriented, no convulsion noted after operation, weakness reduced, and headache subsided, vision normal. Preoperative findings was more marked is muscle power, that is right-sided 1/5, and some exaggerated jerk in right-sided knee and ankle jerk, and other neurological examination reveals normal. So she was diagnosed as a carcinoma unknown primary, and evaluation for her primary, we have done some marker study, which is all come, didn't give us any clue. So further PET scan was advised, and there was a hypermetabolic soft tissue mass 24.5 millimeter in right breast, retroareolar region, and another non-avid mass 15.3 millimeter in lower inner quadrant in the same breast, but multiple hypermetabolic right axillary lymph nodes, SUV maximum 16.9 matted together, and hypermetabolic osteolytic lesion in left arch of the D3 vertebra. Post-op MRI also done. There is no CSF leak. Ill-defined resection cavity seen. Small enhancing tiny foci seen in resection margin area, about 2 in number, which is 5 into 5 and 5 into 4 millimeter in size. This is the post of MRI brain, and you are, I think, able to see the lesions, which is very minimal in contrast enhancements also. This is the PET evaluation. This is the green area marked the D3 vertebral lesion, as well as lower middle portion shows the retroareolar mass, and hopefully you are seeing the axillary matted nodes. So for the confirmation of the breast primary, clinically she was diagnosed as the T2N3M1 disease, and core biopsy confirmed that infiltrating duct cell carcinoma, grade 2. Immunohistochemistry of the breast show ERPR negative, HER2 positive, strongly positive. So for her metastatic lesions, she underwent brain radiotherapy, focal radiotherapy with VMAT, 25 grain 5 fraction in 5 days. And she also received conventional radiotherapy in the D3 region, along with coverage D1, D2, 30 gray in 10 fraction. For her systemic breast carcinoma, we have planned for trastuzumab, pertuzumab, and taxane-based schedule. And during the submission of the case, it was not started, but last week she received the first course of chemotherapy. Question to be discussed, this is the radiation field for her brain and spine lesion. Hopefully it is seen. And question and discussion from my end, what will be her local management in case of good response after 4 to 6 cycles of TPH, and what will be the further genetic testing for this patient? Thank you.
First of all, I'd like to request Professor Don S. Dizon sir to have your valuable comments on this case and what should be the guidance for this very complicated case. Don Dizon sir.
Yeah. I mean, I think it's a very interesting case. She falls into the category of pregnancy-associated breast cancer, right? Even though her baby was born more than a year ago. So the fact that she's still breastfeeding, it does fall into that category. And unfortunately, as we all know, women who are pregnant or breastfeeding and develop breast cancer, there is often that delay in diagnosis. Most oftentimes, it's considered to be just a something normal that happens during breastfeeding, and it's unfortunate, but oftentimes you will see a more advanced disease. I think your plan to do TPH makes sense, since the primary brain tumor was already managed definitively, given that she underwent craniotomy and then radiation therapy. We should also note that there is that new drug, which I'll get to in a moment, tucatinib, which might play a role subsequently if she does relapse in the CNS. I think in terms of the bigger question, she's presenting with metastatic disease. It appears it's in the bones as well as already in the brain. There was a randomized trial that was presented by Seema Khan. It was a cooperative group trial here in the United States, just at ASCO this year. So the question on the table was whether or not local management of the breast or the axilla provides benefit in terms of outcomes, breast cancer outcomes, in women presenting with de novo stage 4 breast cancer. In that study, volunteers either underwent treatment, and in the context of a systemic response, there was a randomization towards breast surgery and axillary management versus continuation of systemic therapy. There was no survival advantage at all to breast management in the context of stage 4 breast cancer. Disease-free or overall survival was unchanged. So you could interpret that one of two ways, right? So in the one way, overall, the survival is not improved, but at the same time, you're also not, she's not being harmed by doing a breast surgery. My concern obviously would be if you don't have local control, this might prove to be a very big problem for this woman going forward. It might break through the skin. Alternatively, you could do TPH and maybe do with a sort of neoadjuvant context of the breast and see if she resolves. If she does have a resolution of the breast primary and the axilla, which she just might because it's hormone receptor negative and HER2 positive, I think the dilemma will be, do you go ahead and do the surgery versus nil? I don't think there's anything saying you have to do the surgery. In fact, there's data now suggesting there really is no benefit. So if she's responding to Herceptin-based therapy or trastuzumab-based therapy, I would not break the therapy to allow for the surgery. I would plan to just continue on with the treatment. So TPH, 4 to 6 cycles, and then I would probably continue her on Herceptin going forward. Because again, this is not an adjuvant context. With pertuzumab, you have to worry about the side effects. The diarrhea is rate limiting oftentimes. But yeah, I agree. TPH would be the way I would propose to start treatment, especially in the context that her brain mets has been managed. So let me just see if there was a second question that you had. So I would absolutely get genetic testing on this patient as well. Here, we would send her to a genetic counselor who would help guide the most appropriate test. She has no family history of breast or ovarian cancer. They may recommend just a breast stat panel looking for breast cancer associated genes. But yeah, I do think it's very important to make sure that she doesn't have a mutation that is actionable, not now, but later, and certainly might have implications for her family.
Thank you, sir, for your valuable comment. I'd like to request Professor Qamruzzaman Chowdhury, sir, regarding your comment on this case. Any change of treatment plan, or you want to add anything?
Professor Don Dizon has explained about this, especially the benefits of primary surgery, especially in the case of this metastatic breast cancer. Because if you see, a lot of data has been published, those are not randomized. Like even the meta-analysis shows that there is no benefit actually having surgery after having a chemotherapy in stage 4 disease. So, but one question always in my mind, since the primary is very small, even the tumor burden, metastatic tumor burden, not that much, which is excised as a oligometastasis. Even the bone emission is very small. So I think whether surgery can be after total treatments, surgery can be in consideration or not. I think we can think later on. But if you have a if you have a bird's eye view of the total data, like Canadian trials and also the Turkish trial and Indian trial, all the trials fail to show the surgery in metastatic breast cancer does not have an overall survival actually. And regarding the genetic test, I definitely because we don't know, we just doesn't have any mutational studies though. So in future, when the patient becomes resistant to this present management, we can think about the other molecular targeted agents that may come in consideration later on.
Do you know the frequency of mutations in BRCA1 or 2 in your population?
As Bangladesh doesn't have these facilities, we doesn't know actually in Bangladesh how much the patients has what percentage of the patients has mutations in our country, because we don't have the lab here.
I always think of genomic testing as more relevant in hormone positive breast cancers, where we're looking for PIK3CA mutations or something other than actionable. I think in HER2 positive disease, I'm less inclined to do tumor-related genetic testing for actionable mutations, only insofar as HER2 is such a good target for us in the first, second, third, and subsequent lines.
And presently, we are also doing some CGP from Bangladesh, which is not available in Bangladesh. We are doing in the Boston. Some cases we are doing just comprehensive genomic profile. In some cases, not in all.
Yeah. I think it's good. It's good to learn, especially because, there are very likely some socio-demographic differences in the genomic profiling between breast tumors in the U.S. versus in Bangladesh. Absolutely.
Especially the Asian population, because we found the genetic mutations more, especially in the Asian population in the lung cancer. We doesn't know whether any mutation have in the Asian populations like Bangladesh. Okay, we don't know.
Yeah, I agree. The other thing we would do in this, and for this particular woman, is we would give her something to help sustain her bones, given the likelihood she has lytic lesions in her vertebra. So here we tend to use Zometa or zoledronic acid, which we can do monthly for 3 months and then switch to every 3 or 6 months. But it's important that we take care of her bones while you're treating.
Yeah, that we do also.
Yeah, perfect. Yeah, that's the only thing.
Okay, we'd also like to hear from our other panelists. I guess Dr. Salim Reza sir is with us.
Regarding the management, definitely I am agree with the other two speakers. In these cases, regarding the local regional management, only if there is a tumor burden in the breast and it is a tough symptoms, then it can be done as a palliative surgery. But that will not get. I have a query. As the disease is stage 4 disease, brain mets, bone mets, even primary disease here, then after TPH, after sometimes the patient may not respond well, and patient may if the patient do not respond well, then what will be the next treatment protocol for this purpose?
So if she does not respond to TPH, what would we do next?
Yes, sir.
I guess that is the question. If the patient is not responding to TPH.
Yeah, I mean, I think there are multiple options for second line or even third line therapy. We could try to take her off. I would discontinue the pertuzumab. You can try another Herceptin combination, maybe with vinorelbine. You could try with capecitabine plus Herceptin. If you have access, there are different HER2-directed drugs like neratinib, which could be tried. There have been 2 new approvals in the United States recently. One is trastuzumab deruxtecan, which is an antibody-drug conjugate. And then tucatinib was also approved as well. The trastuzumab deruxtecan was given as a single agent, but with tucatinib, it's alongside capecitabine. And the interesting thing with tucatinib, at least, is that if she has a relapse in the brain, this drug has the potential to treat the brain as well. That was also what was seen in the clinical trial. So, I mean, I think there are multiple options, but if it is HER2 positive, you could even, you would continue the trastuzumab-based therapy, just switch out the chemo. You could even use something like a trastuzumab emtansine if you have access to that as well.
Okay, Salim sir, you have anything to add, or we move on to our next panelist?
Move on, please. Thank you.
Thank you. Mofazzel sir is with us. Professor Mofazzel sir, do you want to supplement or comment on the case?
Well, thank you for asking me to put a comment on the case. Already the comments have been made and I fully agree with those comments. But about the local treatment, if the response is subnormal, suboptimal, probably if the patient gets symptoms, as Dr. Salim Reza said, if there is local symptom, probably surgery may not be a good choice, but as an alternate to that, can we go for a local radiotherapy? As we know that the survival of this patient, HER2 positive disease, as well as brain metastasis, and probably she was harboring the disease for a long time before it was evident. So the survival of this patient already has sport disease with bone mets, and if she does not respond to the protocol that has been decided to administer, she will have probably a devastating disease and survival will be short. In that particular case, I will, depending on the response, I will also consider a local radiotherapy if there is a necessity. About the second point about the genetic testing, yes, genetic testing must be done as Dizon said, because there are a lot of molecular alterations, and cascade testing can detect many things which can help in subsequent treatment, as we are very apprehensive about the non-responsiveness of the initial treatment that we have planned. So the further treatment like this azotrastuzumab emtansine, as Professor Dizon said, and the other one, the tucatinib, capecitabine, trastuzumab, or even lapatinib and capecitabine is an alternative, because lapatinib has some activity in the brain also. So I will consider that as well.
I would agree with you completely. And yes, you're absolutely correct. I mean, I think the risk here, she has a risk of both systemic progression, but also of local progression. I would say that the local progression is likely to influence her quality of life more, especially if she develops lymphedema due to progression in her nodes, or even skin breakdown due to progression of the mass, in which case I think maximizing the options for local control becomes very important, but not in terms of extending her survival. It's really a palliative approach at that point, and approaching local treatment for palliation completely makes sense.
Oranshu, I have one supplement question, if you allow. What will be the evaluation method after 6 cycles of TPH therapy? Should we go do for the breast MRI as well with the PET scan?
You know, I think if you're not looking, and I would defer to our surgeons and radiation oncologists here, if you're deferring the management of the breast due to, say, a clinical response, I would just do a PET scan.
Professor Salma Sultana, madam, is with us. Madam, you want to comment on this case?
Thank you, Arunakshu. As it is a stage 4 disease at this moment, and she was diagnosed retrogradely. Metastasis was diagnosed first, then the primary site was sought out. And though the primary site is very small, the T2, but at this moment, I think there is no role of surgery. We must, as she is having multiple site metastasis in the bone, in the brain. So I think systemic therapy, as my colleagues have made the consensus, it should go on. And after the systemic therapy, we can review the case. And till now, the data and all the studies and meta-analysis, all of them doesn't support surgery for in sense of survival benefit. So I think surgery should not be the option in this patient, and we should go for systemic therapy. Thank you. And regarding the genetic testing, I am also in favor of doing the genetic testing, because we should know the mutation, whether she is having it or not, for her counseling regarding other family members. And regarding the question of Dr. John, that actually we don't know in our country the percentage of the BRCA1-2 mutations. We do advise our patients, those who are having the familial breast cancer or family history of breast cancer, we do advise, but this is expensive, quite expensive testing. And though we have some labs doing these tests in Bangladesh, but many of the patients don't go for the test. That's why we don't have any data.
And they don't go for the test because of the expense?
Expense is one thing, yes.
Actually, Professor Das, I just have one comment more about the case. I think it might be important to review the brain pathology against the breast biopsy. I'm noting that in the brain, it was called poorly differentiated, but in the breast, it was a moderately differentiated cancer. So if at all, it might be important just to check HER2 and ERPR on the brain and do a direct correlation to make sure we're not being led astray. It would be exceptionally rare, but unfortunately here in Rhode Island, for example, we see a lot of dual primaries at presentation, more than I'm comfortable with. So I would just do that, wrap it up and just compare the pathologies together.
Yes, I think the question Professor Don has said, that is a very important question, that there could be two primaries at the same time, because only on the brain tissue we have done only TTF1. So if we could do GATA3 is an important marker to exclude breast primary. So that was an option. We could do that to determine, because yes, in the brain lesion that was diagnosed as poorly differentiated carcinoma, and also then again in the breast it was invasive ductal carcinoma. But I think yes, GATA3 could give a clue. And yes, I also agree that it could be primary somewhere else maybe, because there are so many metastases at so many places. And also another point I would like to emphasize on is that when the patient has visited second time during her early after childbirth, at that time along with FNAC, if a core biopsy would have been on the retroareolar mass, I think maybe we could find something else, because core biopsy is more confirmatory rather than FNAC. So I think that was also another.
Yes, there was probably a lapse. This could be detected much earlier if the core biopsy would have been done. I fully agree with you.
Yeah, would have been done. Yeah. That's the point I wanted.